So MUK9 was designed based on what we know about genetically defined high-risk myeloma already, which is that there is a patient group primarily defined by having adverse cytogenetics who unfortunately have really quite a poor outcome associated with conventional chemotherapy approaches. So the focus of MUK9 is on the younger, potentially transplant-eligible population. We've undertaken analysis of the Myeloma 11 data, looking at patients who had one or more of the classically defined high-risk genetic abnormalities, and that's the presence of the 414, 1416, or 1420 translocations, and or gain of chromosome 1q or deletion of 1p or 17p. And added into that using gene expression profiling to define a gene expression high-risk population. And by combining these different factors, we were able to identify that those patients who had two or more high-risk abnormalities, either conventional genetics or by gene expression profiling, had really fairly poor outcome, even with what we might regard as gold standard treatment at the moment from myeloma 11, which will either be a lenalidomide-based or thalidomide-based induction, potentially even including carfilzomib within that data set. And in that population who had two or more high-risk abnormalities and were ISS 2 or 3, the median progression-free survival was actually only 20 months, and that includes autologous stem cell transplant as well. So really that's a group where we've not seen, unfortunately, huge progress over the last 5 or 10 years in terms of outcomes. So the MUK9 study was designed to really look at other ways of trying to get deeper and, most importantly, prolonged responses to chemotherapy. So what we were able to present at BSH is the preliminary data in terms of the feasibility of the MUK9 approach. And it's really one of the first studies internationally, in fact, where we've been able to preemptively change the treatment pathway based on genetic results. So the trial's now closed, recruited over 2 years until the summer of 2019. And whilst we've not got any clinical outcome data yet, we have got the initial feasibility data. And the trial was designed in such a way that patients could go into the study. They would have baseline genetic tests undertaken, looking for those high-risk conventional abnormalities, but also using the Sky92 gene expression platform to identify high risk defined by gene expression profiling. And those patients who had two or more high-risk abnormalities then had the option of going into the high-risk arm, or what we called optimum treatment arm. Because obviously many of those patients would potentially need to be treated before waiting for those results becoming back, patients are able to start standard treatment with typically VTD, which is a UK standard of care. And then within 1 to 2 cycles of starting VTD, the concept was that those high-risk genetic results would come back, and then patients could potentially be diverted into a different treatment arm, the optimum treatment arm, which consisted of a 5-drug induction. So acknowledging it's a fairly intensive approach, but really aiming to tackle the most aggressive disease with a multimodality approach, including an alkylator, so cyclophosphamide, a proteasome inhibitor with bortezomib, an IMiD with lenalidomide, dexamethasone as a conventional backbone agent, but also daratumumab as a CD38 monoclonal antibody. So patients who deemed high risk would start 1 or 2 cycles of VTD, go into the high risk arm, and receive up to 6 cycles of Dara-CVRD induction, followed by stem cell harvest, followed by an augmented stem cell transplant with melphalan plus Velcade, which we felt was important to try and avoid that early relapse that we sometimes see in the genetically defined high-risk patients. And then from 3 months post-transplant to go on to 18 months of consolidation with Velcade, lenalidomide, daratumumab, and dexamethasone for the first 6 of those 18 months, followed by long-term lenalidomide and daratumumab maintenance. So as I say, the trial is now closed. 472 patients went into that study. And really, the primary analysis of the feasibility was whether it was possible to turn around the genetic testing within what we had pre-specified as being 8 weeks, which would equate to 2 cycles of induction chemotherapy. And in fact, very encouragingly, we were able to turn around those results within 18 days. Those analyses were all undertaken at the Institute of Cancer Research by Martin Kaiser and his team. Of the samples that were received, actually 38% were deemed high risk and were potentially eligible for the MUK Nine Optimum study. And of the analysis so far, when the trial closed to recruitment in the summer of 2019, 108 patients entered the treatment arm in MUK 9B, and 251 patients remain on follow-up from a standard risk perspective.